Hi, my name is Rachel Daniels, and I'm presenting Swanson's Theory of Caring for the Department of Nursing, University of Hartford, Theoretical Perspectives in Nursing. Kristen Swanson has served in nursing for over 40 years, receiving her BS in nursing in 1975 from University of Rhode Island. 3 years later, she received her MSN in 1978 from University of Pennsylvania, and then 5 years later received her PhD from the University of Colorado. During her doctoral studies, she developed the Swanson theory of caring. While being well known for this theory, she is also known for her research on pregnancy loss and has published over 100 articles, book chapters, and given hundreds of presentations and consultations to advance the science related to caring in nursing. Swanson's theory of caring has provided much needed guidance for the advancement of nursing science and for the quality of nursing practice in all clinical settings. Her contributions to nursing science and her leadership in nursing education has improved the profession globally. Swanson's theory of caring is defined as a nurturing way of relating to someone who they have a personal sense of commitment and responsibility to, and making them feel valued. This theory is based on the idea that nurses demonstrating they care about patients is as important to patient well-being as the clinical activities provided. Swanson first introduced the theory of caring with the introduction of 5 caring processes in 1991, later expanding and reorganizing the process in 1993 and 1998. It considers and cares for the whole person and is the foundation for better healing and better care. Swanson's caring theory identifies 5 categories: knowing, being with, doing for, enabling, and maintaining belief. Knowing is identified as the care provider striving to understand an event because it has meaning to the patient or persons. The following subcategories of knowing are avoiding assumptions, centering on the one being cared for, assessing thoroughly, seeking cues, and engaging the patient, family, and healthcare team. Being with is defined as being emotionally present. It is more than understanding because it is becoming emotionally open to the other's reality. The message conveyed through being with is that the other's experience matters. Doing for is characterized by acting on behalf of the patient as if they were able to do for themselves, being protective of the patient's needs, and performing duties competently and skillfully while preserving dignity. Enabling is illustrated by providing information, support, and validation to navigate one's passage through life's transitions and unfamiliar events while facilitating the capacity to grow from the situation. Maintaining belief is defined as sustaining faith in the capacity to get through an event or transition. Believing in the patient and maintaining a hope-filled attitude, offering realistic optimism and going the distance, having faith in facing the future with meaning. When a provider takes the time to know, be with, do for, enable, and maintain belief in the other, the recipient feels a sense of healing and wholeness. They then feel understood, valued, safe, comforted, capable, and hopeful for the future. The widely accepted meta-paradigm concepts introduced by Fawcett are a way to distinguish nursing as a discipline and include person, nurse, environment, and health. Swanson's 5 processes presented in the theory of caring meet all the facets of the paradigm. A nurse taking time to understand the meaning of a life event is the person-nurse health relationship and referred to as knowing. what it is like for me, the patient, personally. Being with transcends understanding to realizing the respecting emotions of the patient. This speaks to the nurse-patient environment relationship. Commonly assumed that being with is just a physical connotation, but it is also a psychological piece as well. When nurses are emotionally present to the sorrow, fear, joy, frustration of the patient, they feel like their experience and situation matters. Doing for is acting on behalf of the patient in a nurse-health relationship, as well as doing it as if the patient would do it for themselves, thus utilizing the nurse's knowledge and physical capacity to do so. Enabling is providing the information and support through the person-health relationship. This part facilitates the other's capacity to get through a situation. Maintaining belief is considered the core caring process that encompasses the other four processes of caring. It speaks to the person-environment health of the paradigm and can sustain faith and encourage and give hope that a person has it within to get through an event or transition and face the future with meaning. In the article Implementing a Caring Model by Sandra Mathis, she discusses implementation of the SCT model at a Louisiana hospital that empowers nurses in the spirit of caring within their teams on their unit using a relationship-based care model. The units implemented specific ways of building collegial relationships and patient-centered care approaches, as well as focusing on self-care. In the article Insights from Kristen M. Swanson's Theory of Caring, the authors reference the Carolina Care Model based on the SCT that promotes patient care at the University of North Carolina hospitals. The caring theory ensures consistent high standards of nursing are applied to improve the patient and family hospital experience. The model includes multi-level rounds summarized in the acronym R for pain, O for positioning, U for toileting, N for needs anything, D for privacy, S for safety. The multi-level rounding encompasses the being with and doing for. Words and ways that work talk about communication across caregivers. Providing wisdom on the best ways to interact with a specific patient encompasses enabling and being with. Relationship and service enable nurses to provide a moment of caring, 3 to 5 minutes with a patient that focuses on their care and their needs. This encompasses knowing and being with. Relationship and service also has a no passing zone, which provides a commitment to answering call bells. This encompasses doing. Lastly, partnership with support services enables patient-centered teamwork, doing for. Carolina Care has led to sustained and impressive improved care outcomes. Patient satisfaction scores in nursing and overall care have risen sharply. Satisfaction with pain control has increased, and promptness in answering call bells has also improved. Strengths of the SCT are that it places the patient at the center of focus, builds trust, promotes healing and health through relationship, preserves patient dignity, achieves possible outcomes, promotes a caring, healing environment. It is also a rational and simple theory to utilize in improving nursing practice. Some limitations include that it doesn't address the biophysical needs such as food, fluid, elimination, and ventilation of the patient. It's not as high of a priority as is being there with the patient, developing that relationship. Also, environmental challenges such as the diminishing workforce, the demands on nursing, low staffing, burnouts of staff, acuity of patients. It doesn't consider organizational structures and policies, as well as communication barriers, lack of knowledge, understanding, culture, and patient perspective. Personal application of the SET. Working in the operating room provides its own sets of highs and lows. Unknowingly, I have used the SET during preoperative interviews. I had a 19-year-old patient going for a myomectomy. She was visibly scared and crying. Though I was charged that day and would not be in the room through her whole case, I assured her when she was being induced and extubated, I would be there. I sat and listened to all her concerns and answered her questions, and then coordinated with the anesthesia team, the surgeon, to provide the best care for her. Afterwards, I organized with PACU to give her a private room and helped to assist her ambulate after her propofol wore off. One of the lows in the operating room pertaining to this theory is doing an organ procurement. Swanson developed her theory based on her perinatal practice and then realized this can apply to all of nursing. In an organ donation case, there are days, if not weeks, involved of preparation for these cases, mainly because the active care is not only provided to the patient but the family. While nurses do care for the patient who might have had a tragic accident, overdosed, who has just been declared brain dead, or is a donation after cardiac arrest, this process takes a toll on the families. Recently, I had to facilitate a family as they made the decision to say goodbye to their family member. I coordinated with PACU, set up a room with bereavement trays and bunny suits so that they can enter the sterile OR environment. I sat with the family and waited with them while they said goodbye to their loved one. And we sat in the room and waited for asystole before taking the kidneys and liver. Their family member had just committed suicide, and it was important to be present and focus on the family's concerns, providing empathy and a caring touch and just listening. Providing this seamless process during their grief and giving them resources with donor services was all a part of how implementing the Swansons caring theory in my day-to-day practice is apparent. Case study. Jennifer is a 32-year-old female presenting for a suction D&C at 10 weeks of her pregnancy. Her and her husband had been wanting to have a baby and were elated when they got a positive pregnancy test. During her initial visit, there was no heartbeat, and the couple was devastated. Her OBGYN directly admitted her for an immediate procedure. In the preoperative area, the Swanson's caring theory was evident by how the nurse entered the room and sat to answer all her questions. She spoke with tenderness and made sure to include the husband in the discussion. The nurse used eye contact and remained close to Jennifer to provide support when she became tearful. Being with was expressed by Jennifer because she felt her providers were in this together with them. Ever since the initial booking of her first appointment, as well as follow-up phone calls from the nurse's office, she never felt alone in this experience. When Jennifer realized all the team members were working together on her behalf, then doing for was revealed. She saw how the interprofessional collaboration worked seamlessly together from start to finish. Her husband also expressed that he felt their situation was upheld with dignity and the couple's decisions were honored and protected. The couple expressed feelings that they were at their lowest point, because they lost their first baby and now they're dealing with this. They relied on prayer and family to get them through this event. Enabling and maintaining belief was conveyed when the providers demonstrated belief that the couple would get through this experience and encouraged the parents to participate in grief counseling. Jennifer and her husband felt their care team provided emotional support and guidance during a tough time, and they were hopeful for their future family planning. In conclusion, the measure of caring's worth is determined by whether it leads to the recipient feeling seen and intact or enhanced, versus diminished and dismissed. Thank you for listening to my presentation.